So it is my great pleasure to introduce our moderator, Trisha de Borchgrave, to lead this session. Trisha is a freelance writer and senior associate at Global Women Leaders Strategic Philanthropy. Trisha, the virtual flow is yours.
Thank you. Can you hear me? Can everybody hear me? I hope so. So a big welcome to everybody, a big online welcome. And thank you for the Women's Forum for getting us into this immersive new reality of ours. And hopefully, fingers crossed, it will work. Now, the COVID-19 crisis is really leading all our countries to rethink what exactly constitutes national resilience, whereas I think perhaps even a few short months ago, that concept would be framed around national security and defense spending and manpower and weapon systems. Today, actually, we know that the risk inherent today in policies that don't ensure proper healthcare infrastructure, don't guarantee equal access to universal healthcare, pose more of a threat, if not both in our developing economies and in our developed economies. And women have been the first responders to this crisis. We know that 1 in 3 jobs held by women has been deemed essential. In Germany, that's actually up to 75% of those jobs. This is in food security and teaching, but of course in the front line of healthcare work today. And so this perhaps is the wake-up call to women's significant, invaluable, but very undeserved role in society. We know they make up more than 70% of healthcare workers worldwide. This is in public health capacity, in immunization, in high quality care for the elderly, for the infirm, for those who have disabilities, and in community health. And interestingly, up to 90% of nurses in Wuhan at the height of the pandemic have been women. Equally, home health and care aides earn just above a minimum living wage. They're exempt from basic labor protections. And since they're not recognized for their work, they have no certificate or no qualification as such, they have been exempted from PPE, from personal protection equipment altogether. And women today are struggling with ill-fitting PPE, which is designed for men. And so, as I said, women have been the first responders to this crisis, but not in the decision-making roles responding to the crisis. You look at the White House coronavirus task force, that's over 90% men. You look at Boris Johnson's pandemic team as such, that's all men. And in fact, another man has just been added to that team to look into the surge of domestic violence and domestic murders that have been happening during this pandemic in the UK, which brings me to the point that women hold just 20% of leadership positions in the healthcare sector, which is the sector in which they overwhelmingly work in. Also, closing the frontline gender gap in healthcare is about women's health, not just as healthcare workers, but in their human right to health, in their right to have control over and choose freely over matters of their own sexuality, which of course includes their sexual and reproductive health. And when this goes missing, hundreds of thousands of women and girls die from unintended pregnancies, from unsafe childbearing, from HIV infection, and from sexual violence. And if most of us think that those are issues, however tragic, that belong to the developing world, really these kind of issues are at the heart of the developed world, in which the gender gap on the developments of treatments and of diagnosis of all health conditions, from headaches to heart attacks, is having a very serious impact on health. And actually, one of our speakers has written eloquently about this, and I sort of paraphrase, quote her, when she says that women today continue to be misunderstood, mistreated, and misdiagnosed because we continue to be seen as an aberration, as an abnormality to the default position, the default role model of male physiognomies. And this is also killing women today. So this session is about how can this post COVID new normal become the better normal, in which G7 countries can really genuinely coalesce around policies that prioritize that requisite level of urgency and investment and commitment to this very entrenched gender injustice in the healthcare sector. What kinds of recommendations should we be making at this point for gender responsive budgeting and gender responsive decision making to tackle this implementation gap at this critical juncture in our human history? And to answer these questions and so much more, we're delighted to introduce to you this formidable panel of speakers. I'm just delighted to have you all here. Please welcome Katja Iversen. She's the president and CEO of Women Deliver. This is the global advocate of gender equality and the rights of health for girls and women. And according to a friend of mine yesterday who private messaged me, she is his hero. So that's in good standing there. Welcome to Ulrike Decoene. She is the group head of communication, brand and corporate responsibility at the formidable company of AXA. And a warm welcome to Caroline Criado Perez. She is the author of Invisible Women. Someone is saying, fine, okay, here we go. Author of Invisible Women. Now, I'm sure many of you have read her book or at least listened to her book. It has received richly deserved accolades. A big bravo to her deep dive into the gender data gap and all that affects in terms of every single aspect of our living lives, including probably the design of the piece of furniture that you're sitting in right now. So a warm welcome to you all. I wanted, if I may, to start with Caroline. What we're going to do is to have a discussion here, but we'll welcome all your questions online, and that will start to be curated and filtered through, and hopefully we will get lots of audience participation. Now, Caroline, if I may start with you, you have really looked into big time all the statistics about the gender data in healthcare. I'm going to start off with a sort of generalized question, but I'm going to ask you to sort of jump into this. There is this enormous gap between what nurses in healthcare are paid and the value that they give to society, and nowhere has that been more clear right now. Mm. Nurses throughout universally complain that they're underused and they're undervalued, that they're more than capable of doing and qualified to doing a lot more responsible jobs in the healthcare sector. Are we stuck right now in the healthcare sector, maybe even us ourselves as citizens? Are we in 2020 looking at stereotypical and inaccurate portrayals of women in healthcare? Caroline?
Well, I mean, in many ways, yes. You know, I think if you ask someone, for example, to picture a nurse, they'll probably picture a woman. If you ask them to picture a doctor, they'll likely picture a man, even though actually women also dominate as doctors. So you were talking there about some statistics around the world. Across the EU, I think the stats for healthcare workers are 75% female. In the UK specifically, it's 77% female, rising to 89% for nurses. And you also mentioned healthcare workers. And again, that's 84% female here in the UK. So these are very, very heavily dominated female workforces. But of course, the higher up the ladder you get, it becomes male dominated. And it's almost quite impressive how male-dominated leadership in health is, given how female-dominated it is overall. And you mentioned there that we've managed to find yet another man to add to the exclusively male UK task force. And again, in that particular sector, you know, it's great that there are men working in the male violence against women sector, but it is quite impressive to have found a man to lead that response, given how heavily female-dominated that sector is. So there does seem to be very clearly something going on in terms of what we think of as a competent leader. And what's been really interesting about this moment in particular in terms of leadership, of course, has been something that a lot of people have been talking about in terms of, well, what does make a competent, successful leader in this moment of crisis, when the crisis is being perpetrated by a virus rather than, you know, as you were very eloquently pointing out, this issue of, you know, normally thinking about it from a defense perspective, and using terms like manpower, which obviously is in itself a default male term. And it's been interesting to me as well how some of the language around this crisis, we have been using warlike language. You know, we're fighting a battle against a virus. I appreciated you saying that women have been the first responders. A lot of people are talking about them as being on the front lines. So again, you know, evoking these images of battle and having to go to war against a virus. And actually the leaders that have been most successful in this crisis have not actually been those who have been presenting this as a battle and us and them and getting, you know, all fired up by the use of, I don't know, missiles against a virus. It's actually been leaders who've been able to be empathetic and bring other people in and be strong enough, you know, to bring in diverse opinions, to engage with opinions that might differ from their opinions, which is something that we've seen in the UK has been a real struggle for our government. So I think it's not so much perhaps that we have, you know, this sort of narrow view of what women in healthcare can be. It's more in respect to that specific question, what our narrow view of what a successful leader looks like. And I feel like this crisis is really providing a challenge to that. And I hope that this crisis can provide a jumping off point for reassessing so much of what we value, and to come back to the idea of, you know, how are nurses being valued, how are care workers being valued. They are not nurses, but care workers are seen as unskilled workers. And that is why they get paid so little. And that is why you don't really need any qualifications. And it's this very skewed idea of what actually is important. And what this crisis has brought out, I think, is that we perhaps have been valuing the wrong things. And suddenly we're realizing how important it is to have a healthy population, how public health is so much more important to our daily lives than defense, how having people who look after us is so much more important than having people who fight with us.
So Caroline, at this point, can I just interrupt you? Very sorry. I know that there's a whole other thing about being interrupted, and I get that. So forgive me about that. But you've written a lot. I'm trying to think of ways that this is going to raise the profile, the awareness of women in this sector. And obviously, there's a sort of a real hierarchical structure based around people's safety. And so there's always this default position that men are in charge of people's safety. And that's changed around leadership now. This is not about flying a plane. It's about keeping that plane up in the sky safely over a long period of time. It's that kind of challenge, which I think women are looking to be better at. But I was very interested. I mean, your book is absolutely fascinating, but you talked a lot about ADR, about adverse drug reaction, because of this gender disparity we have in the medical profession in terms of diagnosis, in terms of drug treatments, in terms of how women are treated. What works for a man often kills a woman, but we haven't looked into that. We don't have the data. And there's been, right now in our search to find the COVID vaccine, which may or may not happen, there's been a lot of talk about these open source platforms that are, collaborative platforms and data sharing platforms away from the big lucrative development of drugs, the sort of big pharma blockbuster drugs, for more drugs of merit. And I'm wondering whether this is a way into creating a more level playing field for women to have the treatment and the diagnosis and being treated in healthcare with that amount of parity. Do you see what I'm saying? Can we raise that awareness enough to start to populate it in ways that we now look like we're competent? Do you see what I'm saying?
Well, I mean, open source data is always preferable from my position because it's transparent and you can actually see what the data is, and therefore you can have a look at the gaps and you have more chance of a diverse group of people being able to analyze that data and point out the flaws with it.
Yeah.
But ultimately, that's not going to be the solution, because the solution is to always be collecting sex disaggregated data and to always make sure that, I mean, the issues, the problems are so, there's so many of them and they're so conjoined. You know, it's to do with who gets funding, how the funding is decided upon, you know, what is the medical treatment we think is important to explore. And of course, there's all these historical data gaps. I mean, to think about COVID-19 specifically, this is a disease where the sex disparity could not be clearer. And yet we are still having to really plead with governments to both collect and publish systematically sex disaggregated data on who is getting a test, what are the symptoms, who is testing positive, and who is dying. And even in this moment where men are being more likely to die, it's been really difficult to get hold of data, global data, that will tell us exactly why that is. You know, are they more likely to get it? Is there some biological reason? Is there some social factor that in terms of male behavior? And if you don't have data on all those points, it's going to be much harder to be able to determine that. And if you look at the historical data gap, where we have historically only looked at the male immune system, I mean, not only we've looked a bit at the female immune system, but it's seen as this sort of atypical thing. It's complicated. You know, you got all these hormones going on there. Nobody knows what's going on there. We don't want to get involved in it. And so we've kind of ignored the female immune system. And now, of course, we've come to a point where we don't know why women are surviving this better, you know, because we don't really understand how the female immune system works. And so we have these sort of wild stabs in the dark where we're injecting estrogen into male patients thinking, will that work? We don't know. I mean, the research that I've read has suggested that actually it's not just the hormones, it's the interaction of the female hormones with the female cell. So one really fascinating study that I reported on in Invisible Women looked at male and female cells and how they responded to estrogen in terms of being able to fight off a virus. And the female cells responded to the estrogen, the male cells didn't. But that study was done in 2016, a cell study, a small scale cell study done in 2016. That is the level at which we are at when it comes to understanding the female immune system and how it works. So yes, absolutely, open source data is a huge step forward and I welcome it, but there's so much more going on here that needs to be fixed. And it really is attitudinal. It comes from this central attitude of the male body as the default body, and we can extrapolate from the male body everything we need to know for the female body. And you still have people making that argument, you know, clever people, scientists, politicians, you know, will say this to me. And you sort of think, well, actually, when you look at the data on who is surviving, for example, car crashes, you know, who is getting sick from whatever diseases, who is being misdiagnosed, you very clearly cannot extrapolate from medical data.
Very, I mean, absolutely fascinating. And we could have the next couple of days talking about that because it's one thing after another. I wanted to turn to Katja, if I could, because you're concerned with obviously global health. And when things go wrong in society, in the world, as it has right now with a pandemic such as COVID, it's really often in the post-recovery phase that women die from indirect effects of a crisis, when attention is sort of diverted from their own specific needs, their healthcare needs. We know that infant and maternal rates go shooting up, and the impact on their sexual and reproductive health is massive. What are you seeing in the COVID-19 context in this, with reference to women's sexual and reproductive health, and what can we safeguard against this in a post-COVID environment? You have to unmute yourself. Yeah, unmute. I can still see you muted. There we go.
Thank you. Thank you. Hey. So thanks a lot, and what a great lineup. And I could also listen to Caroline for a long time. So let me just break it to you. You know, we know that even in a pandemic, people still have sex, girls and women still become pregnant, and they still give birth. We want it to be safe. We want it to be wanted. According to studies, this COVID-19 lockdowns across the globe, if that continues 6 months, 47 million more women are projected to lose access to contraception. That's on top of the 214 million who already have an unmet need. We will see that could result in 7 million unintended pregnancies. In addition to that, we have 31 million extra gender-based violence incidents. This is unacceptable. So we really need to look at it, both in the response, but also in the post-COVID and in the recovery. As the crisis identifies, we really need to invest upfront in the disaggregated data, absolutely, but also in those things we know can have effect. We're seeing domestic shelters being turned into COVID wards. We're seeing staff being taken away from reproductive and maternal health and put into COVID. And we know from earlier pandemics that we saw spikes in maternal death and lack of access, stockouts, etc. But we can be smart now, and that is also why we have, from Women Deliver side, fought hard with a lot of great allies to, one, safeguard sexual and reproductive health and rights in the preparedness now, in the response, but also use the full gender lens to the response and the recovery, because we need to have that lens and get the data and do the actions, because we see the gendered consequences coming now. And
you're in, I think you're on the G7 Equality Advisor Council. Is this what you're recommending to G7 governments right now, to push for this, this aggregated data for women?
So that's not the only thing, of course. We got within very short time, days, we got together the two councils, both the Canadian, the first Gender Equality Council from 2018 and the one from 19, got everybody together, and we signed up to a call to action to the G7 leaders on some specific asks, and overarching, it was a gender lens and a gender marker to response and recovery, but also on the call for women in the leadership positions of this, nothing about us without us, right, with gender disaggregated data, with safeguarding of sexual and reproductive health and rights, and proper conditions in terms of gender-based violence, so there's follow through and not just talk, but also walk. We have a great opportunity.
Sorry, I'm just going to turn to Ulrike, because we've got some questions coming in, and so I wanted to turn to Ulrike first, because you represent the private sector and the corporate sector, and the nature of healthcare provision is really changing right now. Even good quality care should now also occur outside the hospital environment. There's a lot of technologies happening in the private sector. I'd like to go back to Caroline on that, because it depends where people are investing in these technologies. Are these new generation technologies impacting positively for women in healthcare?
Absolutely. Thank you, Trisha, and very glad to be on this great panel. So yeah, I'm very happy to represent the point of view of a company of the private sector, and also very active in the health space. So we are a direct witness to a gender gap in the healthcare systems, and we have been on a long journey to try to tackle it. So I fully agree that I think this crisis has really revealed how quickly, as soon as you are in an emergency situation, those specific needs and I would say vulnerability that we know about women are quickly forgotten. But I would like also to see the glass half full, and to say that I think this topic, after the 2 or 3 first weeks of confinement that were very distressing, we've heard a lot of advocates, a lot of new solutions being implemented to protect women also in all these aspects that you were mentioning, access to healthcare, protection from domestic violence. So I think we should actually look at this crisis as an accelerator. How can we accelerate better answers and solutions? So you mentioned technology, and obviously we've seen how technology has solved so many aspects of our lives in this crisis. And I think on the healthcare side, we really need to be accelerating those more after the crisis. Teleconsultation is one which we have been betting on and investing in for a long time. It had been picking up, but not quite entirely, because people were not entirely sure of how useful it could be. And I think this crisis has really demonstrated that when it comes to coordinating care, to emergency advice, need of response, teleconsultation can really be an answer. And when you look at the usage of telemedicine, it's really striking. We've been running stats in our own networks. 60 to 70% of users of telemedicine solutions are women, actually. So you can see how fitting it is in the needs and questions that women can have. Again, it cannot cover all the needs, but it can cover some quick questions that you might have, solutions to a need of prescription of protection, maternity protection, etc. I would say an important topic for me, and it has come across, is how do we also, out of this crisis, accelerate women leadership in the healthcare space? And going back to Caroline's talk, I must say I have been really learning a lot about science, pandemics over these 2 months with many scientists and doctors on TV shows. But look at how overrepresented again there men were. And there again, I think seeing women in role modeling positions in terms of scientists, in terms of doctors that the media give access to is really key, and we could do much better on that. My last point is again on this women leadership topic. We are investing a lot, be it in research or in an ecosystem of entrepreneurs, because our conviction is that for specific women health needs, you will always find that women researchers or women investors or women founders are going to be more prone to really focus on the specific needs of women health, be it reproductive, be it osteoporosis, and all those health issues which we know are creating a greater vulnerability for women across their life.
And actually, it's interesting because one of the questions coming in is about someone saying, this is from Madeline Goodman, University of Witwatersrand. I've long been frustrated about funding allocation towards male-centric studies. But it's also in Caroline's book, she talks about the fact that there's so little interest in technologies for women's health, whether that be pelvic floor exercises or something that helps with that, or breast pumps. There is a massive market out there for these kinds of technologies, and no venture capital coming through. And it also feeds into this idea that no studies for the funding of women's issues. What gives? What can we do to make this happen? Do you think it's just simply through women entrepreneurs? It's got to be at a bigger level, doesn't it?
I think you need to have the whole ecosystem working in the right direction, because obviously you can have the women entrepreneur. If they don't get the funding, if they are going to ask investments from, I would say, a VC investment board entirely composed of men who have no whether endometriosis is, of course. So really, it's again, I think it's really comes out across of everything we're saying here in this panel. Everything is very intertwined. From the research, gendered approach to healthcare, to health research, healthcare approaches, and then the whole ecosystem of where the money is and how can we bring it to a bet on women who are doing amazing stuff when it comes to tech-led solutions for women health. And that's my point of view.
Can I ask all of you at this point, because we're also talking about leadership that feeds into the conditions of women working in healthcare, and perhaps this has nothing to do with AXA, but because of the crisis that's happened around nursing care in this country, in many, where those who've been in nursing homes have suffered the most from COVID. These, at least in the UK, 86% of nursing homes are held by corporations, and this, has been the hub of mortality. So, in terms of women in healthcare, should corporations be doing something different here? You talk about corporate responsibility, but there's now a big, sharp focus on corporations and how they've handled, the rights, the minimum wage that's been going on, the fact that women don't have paid leave, they don't have maternal leave, they don't have sick leave. Should there be some recommendations at this point that sector has to start to change? And I don't mean AXA. I mean you.
No. I agree with you. I have a absolutely strong conviction that private sector has a key role to play, especially if you look at how increasingly. I love the Edelman barometer that measures what are the institutions that are gaining trust across the societies, and actually people are trusting more and more their employers, which also means that they expect more and more. And again, I think there's a lot of progress that can be done maybe in some parts of the world. I know in Europe we are quite protective, but generally the private companies are quite protective. But I think there again in COVID, I was quite amazed to see, even when people are working from home, how many employers had put in place hotlines for mind health support, healthcare advice. So I do agree with you, Trisha, that I think private sector will play a bigger and bigger role in tackling global health challenges, and we do have a responsibility there.
Right. Does anybody want to add to that or not? Because it is. Caroline, do you want to add to?
Yeah, well, just sort of, I think we need to change the way we think about public health and public care. And the issue that we have had, certainly in the UK, in terms of care homes, is this attempt to turn them into a profit-making industry. And that is just very, very difficult because it is hugely dependent on being able to provide care, have people provide care. Employment is the number one cost of caring. It's very, very difficult to figure out how to make it more productive in a way that doesn't lessen its benefits. And that's essentially what we've been seeing in the UK. And so ultimately, I think we need to, get away from thinking about how do we make money out of care and think about care as an investment, as part of our economic investment in the way that we think of roads as part of our economic investment, our investment.
On the other hand, if it's I don't think there's anything wrong for the corporate sector to be involved in the nursing care sector, but perhaps it's a question of taxation and it's a question of regulation, so that corporate accountability is greater when it comes to the quality and the meaning and the fulfillment of a job in care.
Well, I mean, that's all very well, but it's actually very difficult to make a profit from this kind of system. It's just very, very difficult because it's not something that you can technologize or productivity increase away. So unless there's some sort of huge change in the way caring happens, it's really difficult to see how you're going to be able to have a care sector that actually delivers the care that is needed, and that gives the care workers the income, the salary, the training that is needed, that we've been talking about here, and yet still make a profit. These are very, very slim profits that companies are able to make from the care industry.
And yet we know we're going to have a huge dearth. We need care aides, we need more nurses, we're going to have an enormous shortage worldwide. And most of these healthcare workers, female healthcare workers, are migrants. So are we having to, look at our migration policies, which have been quite xenophobic in the last few years?
Yeah, well, absolutely. But it's not just about the migration policies in terms of, which countries or which people were allowed in. It's again this focus on skilled versus unskilled workers and what we think of as an unskilled worker. And most carers under the UK government guidelines would be seen as unskilled workers because they don't earn enough and because the education levels required are not high enough, but mainly because they don't earn enough. Like their earnings are below the threshold that you are allowed to come into this country according to the new immigration rules that the UK government is bringing in. So we are going to have to completely reevaluate the skill level of carers, and that is inevitably going to have a knock-on effect on profit margins, which are already very, very small. So we essentially need a totally different economic model of caring. And we need to be thinking of it as a social infrastructure investment from the government.
Yes. And actually, I wanted, it all comes down to money at the end of the day. And what's interesting with Katja, I just want to ask you, because there was a report just, I think even today, they're talking about how, some African countries have fared better with COVID, and everyone's thinking, gosh, is this because they have greater social cohesion than we do? We're all sort of divided and fighting with each other. But then somebody was talking today and saying, actually, COVID has ended up being a rich person's disease. And so what looks like, gosh, they've really handled this well, is because it's not a disease of poverty. The diseases of poverty are TB, are malaria, are HIV, and those don't get the attention. But when wealthier communities, when politicians are affected by something like COVID, there is much greater mobilization and more budgeting towards that. Are you finding that? Is this what's happening here? Katja?
So, I don't think we've seen anything yet. Let's not say that this is over yet. We might be in a place, I'm based out of New York, so it might be going the right way here, but we have not seen anything yet.
Yeah.
I will say, though, that we are seeing that a lot of countries who have had previous pandemics are dealing with it better because they have tried it before. So, airport screenings, et cetera, were instituted way earlier in for example, West Africa than it was, in Europe and the US.
Yes.
So there's a lot we can learn from pandemic, but we also need to be willing to learn.
And so
we have not seen anything yet.
Because we really do need a couple of hours here, and we haven't even got started. But to conclude, do you as speakers, if you were to present recommendations tomorrow morning to G7 countries, you're in a position to be heard. We want, not just greater representation, but greater fairness within the healthcare systems. What would be your recommendations? Let's, Ulrike, should we start with you from the private sector point of view? Oh, you're on mute. You have to unmute. Oh, it's not working. Okay, I'll turn. Should I turn? Well, Katja, I've got you on screen.
All right. Good.
What are your recommendations?
I have a message, I have an ad, and I have a tweet for the G7 leaders. So the message: apply a gender lens to your pandemic response and recovery efforts, including your financial packages, so we can lay down those tracks for a better and more gender equal future today, for tomorrow starting today. The ad: read the Women Deliver 10 recommendations to gender smart COVID efforts on www.womendeliver.org, and look at the recommendations from the G7 Gender Equality Council, but also what's coming out of here and what we had last week in a big G7 debate with UN Women. And the tweet: G7 leaders and all, apply a hashtag gender lens to hashtag COVID-19 efforts and investments. Engaging and elevating women today benefits all tomorrow. Hashtag WeFG7, hashtag Women4Health.
Fantastic.
Over and out.
Thank you. And Caroline, if you were tomorrow to say, right, how do we fill this gap? 20% of leadership positions are held by women today. What do we do? How do we fill those gaps? Do you believe in quotas? Should we have quotas?
Quotas, absolutely. They are just proven to address what is an uneven playing field. All that quotas do, and I'm quoting the London School of Economics here, their study showed that quotas weed out incompetent men rather than bringing up women who don't match up. So all the research that's ever been done shows that quotas just improves the political class and improves those in the workforce. It's absolutely quotas. But actually my number one message, I guess, well, I've got a couple. As a start off, representation, and that's not just in leadership, that's in who is deciding on funding, who is deciding on what research gets done. All these things are affected by who are the people in the room making that decision at that time. Diversity is not a nice little tick box that you add on at the end. It is absolutely integral to making the right decisions, to allocating resources effectively. And added to that is collect sex disaggregated data, because that is what will lead to a correct allocation of resources. Because if you only know what half the world is doing, how half the world feels, what half the world's body looks like, you will make mistakes and you will design things for only half the world, and you will end up discriminating against and hurting the other half. And also you will waste a lot of money. And I don't have time to give examples of how, but just believe me, you will waste a lot of money.
Well, and read your book, because it's
because all the examples are in there.
Ulrike, have we got you back?
Yes, sorry for that. So I will never be as eloquent as my two co-panelists. So I fully agree. There is no excuse for not having women on the table for each decision you make. There's no view that can be accepted today. Second point, maybe because you were mentioning the private sector, a warning point, watch out for the new trends around teleworking. Are we sure this is not detrimental to women work-life balance and careers? I am very worried about that, and I think we should be very careful when projecting a lot of happiness around how good it is to move to massive teleworking. I do think there are things we need to be cautious about there.
But I think also when you have we got, okay, sorry. Yeah, all right. Can you hear me? Yeah, because I've lost, hear me? Okay,
yeah.
All right. No, I also I think that if you're at a table with those who are decision makers in healthcare, it is essential right now to understand that healthcare is a profession of fulfillment. And if we lose sight of the fact that that is why many people enter this profession, and even if they don't enter it with that in mind, they grow with that in mind. It is an extraordinary human profession to help, to save lives. And if that's taken off in terms of the understanding behind policies, then what have we got left in society? What kind of job is that? So I think at this point, these recommendations have to be made in mind of what this sector is at the end of the day. It's not just women, women, women. It's humanity, 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 and representing humanity. I don't know how we're doing on time. I think Sophie at Women's Forum is going to tell us. Have we got any time left, or
not lose any of them. But listen, it was such a phenomenal panel. I'm not surprised we didn't have enough time for all these questions. But I just wanted to take this opportunity to thank our panelists for your insights. I think your insight about how to draw on data, technology, policy, and women entrepreneurship to address those issues were very interesting. Women are showing us, what successful leadership looks like, and it should not just be in a pandemic, but through any crisis, and even when we are not in times of crisis.